Hi and welcome. I'm trying to learn medicine, today acoustic Neuroma, and after we've done it, we're going to do short impingement training. And if you participate in the short impingement training, then it's at your own risk. And this is in no way a medical advice, we're just learning, we're just reading what is written here. And we're talking about internal anatomy and diseases. But before we go on with acoustic Neuroma, I wanted to go back to what we did in the last part, that was acid regurgitation. Where the first thing, I still don't really know what the word regurgitation means. But excess regurgitation is that there's the end of the esophagus doesn't close properly and the acids of the stomach going partially into the esophagus. And that is not good. What was here? And I wanted to go on now to the last things a little bit faster with it. Now the duration, it is if treated the whole time, and the causes are legs, muscle at the lower end of the esophagus, and at the lower end there is the sphincter. Now I wanted to go to first thing. Was there something of surgery? Causes? Did we have complications? Could be peptic or reflux esophagitis. The lining of the esophagus became inflamed, and narrowing of the esophagus and bleeding can result in anemia. Treatment at home: not to wear too tight clothes, no belts, eat smaller and frequent meals, sit upright when eating, avoid to be overweight, take milky drinks and antacids which coat the lower end of the esophagus, and what the doctor might do: prescribe antacids. If the symptoms persist, he will probably send you to hospital for barium swallow X-ray to investigate the cause. And prevention: about overeating, overdrinking and overweightness. And do not wear tight clothes. Now I was wondering here, they had written here to the food to drink milky drinks and antacids, but I would say there's probably more to it than that. There's certainly probably some foods that exaggerate with how more acidness or whatever, and there's certainly other types of foods which could help maybe. If it's cooked, there are oftentimes multiple things eaten, starting with whatever, and oftentimes ended with something sweet, something heavy in the middle or whatever. I think there's also something maybe possible. And the other thing is, I once heard that, I don't know what it was, but it was something at the trachea, that the trachea could be secured with a mesh around, so even metallic mesh could be, but I think it's not metallic, could be secured, so sewed at the outside of the trachea, and then that would make it open, hold the trachea open. And now the question is, what is the cause of acid regurgitation? They named 3 mechanical influences, like wearing a belt, a seat belt, being overweight, okay, but here, overindulgence, maybe, and bending forward. But it's the only really biological reason, anatomical reason, or disease reason that they named: legs, muscle at the lower end of the esophagus. I thought the problem would be way more complicated with acid regurgitation, and it would be something completely wrong with the hormones and whatever. Is it really just the only anatomical biological reason that the lower end is 2 legs? Is there then not some type of surgery possible to make it a bit more tighter, like with the trachea, to hold it open, or other things? This book is 40 years old, so maybe there are things possible. But if not, then a surgery form has to be developed. I don't know how serious the whole problem is, but it cannot be that the only treatment is to eat a little bit different or whatever. And it probably has not just serious consequences, but probably also milder or not so much noticed consequences. That is something which has to be addressed, and I'm pretty sure a surgery is possible here. And if it does not exist one which goes good and functions good with a good outcome, then one has to be developed. Now to the acoustic Neuroma. That is a rare growth on the acoustic nerve of hearing and balance. Okay, people having an acoustic nerve of hearing and balance. I haven't heard it expressed that way, but I think that that's somewhere in the. The growth is not malignant, but it slowly grows inside the skull and causes pressure on the nerve and surrounding brain. It is this pressure that causes problems, so it's not a malignant growth, it's not a cancer growth or something, but it's still a bad growth. And this grows bigger, and then it pressures against the brain, and that's a problem. So not that the thing is itself is a problem, but it's a problem that it grows bigger and when pressures against the brain. But I can't, well, no, but let's go to the symptoms. It probably makes also some problem for balance and acoustic symptoms. Slowly increasing deafness, often associated with singing in one ear. Okay, over slowly increasing. Slowly, so at least over weeks, I would even guess over years, but I don't know. So slowly increasing deafness, so not to hear on one ear. It would be interesting if both ears are affected or always just one. And singing in one ear, I don't really know what I mean by that. Clumsiness and unsteadiness in walking. Okay, to not walk completely in a straight line. So that can lead then to alcohol control test problems. Clumsiness and unsteadiness in walking. So problems with walking in a straight line. Dizziness, which is not usually severe. So some feeling not completely clear in the brain. But balance in a balanced way. But not that severe with dizziness. In more advanced cases, there may be pain on the side of the face, weakness and headache. Okay, if it grows bigger, then there can be pain on the side of the face. So overall weakness, I guess, and headache. Now, the pain on the side of the face would be interesting if it is just the growth which pressures onto a nerve, onto a facial nerve, or if it is causing that in the brain neurologically, if it's a nerve reason or neurological reason. That would be interesting. Duration. Symptoms may gradually increase over the period from 2 to 10 years, so over years, 2 to 10 years. Causes. It's not known what causes the growth on the nerve of hearing. And here I want to add again that book is 40 years old. So at that time when the book was printed, it was not known what the cause of it is. Complications. Removal of the growth always makes the affected ear deaf. It makes it always deaf. Why? It grows on the acoustic nerve. Is it not possible maybe to just smaller it, to make it a bit smaller, so if the acoustic nerve still works? But it's not that big that it pressures against the brain. So just to, like it happens sometimes with bones, if the bone is big. When to consult the doctor? If there is gradually increasing deafness in one ear, that's especially if there is clumsiness and unsteadiness in walking and dizziness. So we're saying if there's an increasing deafness in one ear, then consult the doctor, and also if there are problems with walking in one straight line. What the doctor might do: examine the ear with an oroscope. That is an instrument with a magnifying lens and a light. The thing is an oroscope. Okay, it's a thing that has a lens on it, like whatever it's called, a lens, and then also a light at the top. So basically like a smartphone. But in the video you can look into the ear, an aeroscope. That also, so by looking at the ear of an aeroscope, when testing the degree to which the patient's hearing is impaired with a tuning fork. By looking how good the ear can still hear. It's an instrument that has two things, and one hits against them and they're making a sound because they're vibrating in the air, and then people can hear the sound. Examine the eyes for nystagmus. But it's a horizontal flickering of the eyes. A horizontal flickering of the eyes does that happen if people have acoustic neuroma? So if they have a problem with the ear, the acoustic neuroma, do they have a nystagmus of the ear? Or is that if they have nystagmus of the ear, then they probably don't have the other thing? Arrange further examination and tests by an ear, nose and throat specialist or a neurologist who will be able to confirm the presence of a growth. Okay, further examination and tests of the ear, also of a nose and of a throat, and also a specialist for nose and throat, and also a neurologist, so someone from the brain, and they were looking, is there actually something growing? If the diagnosis is confirmed, the specialist will arrange for an operation to remove the growth. Now maybe that's a bit simplified or a bit outdated, but it would be interesting if there are other options than the surgical options. And as I already said, is there maybe a partial removal possible so that the hearing stays? Because it seems that the growth itself is not a problem, just the pressure of it. So smaller it would be enough. Prevention. It is not known how to prevent an acoustic neuroma from forming. It has probably something to do with we have no idea what the cause is. Outlook. Although hearing will not be restored in the affected ear, early removal of a tumor, okay, they are saying it is a tumor, I avoided to say it's a tumor, but it is a tumor. Removal of a tumor has good results and leaves few other symptoms. The danger of removal increases as the tumor slowly grows bigger. Okay, the longer people wait, the greater the surgery and the greater the risk is that the surgery makes a problem. Hearing can't be restored, at least not here. But overall, it's pretty okay. Now, that was the medicine part. If you were here for medicine, you can go directly to the next part. We will do now the short impingement training. If you participate in the short impingement training, then it's better the hour risk. Doing shoulder circles. From back, up, in the front, down. Why does it grow on the acoustic nerve? Are there other nerves on which something like that can grow? Is a transplantation of the acoustic nerve possible? Okay, and now we're doing advanced shoulder circuits. Long arms, strong wrists, and we go as far back as we can. High up, and in front, and down, and again back, up, and front, and down, and again up, down, back, down, front, up, back, down. And now we are doing robot lift, good and steady stand, long arms, strong fists, and we're going back with shoulders and together. And not turn the arms to the inside. Shoulders down, hands together, arms to the inside. And now the arms to the outside, shoulders down, hands together. And the arms to the inside, shoulders down, hands together. Step. Arms to the outside, shoulders down. Release. And this one exercise, arms at the outside, hands on the fists, the arms with in front. Turn the arms in front, shoulders down. Now the arms back, shoulders up and front. And the arms in front, shoulders down. And the last time the arms back, shoulders up and in front. And now shock. That's the arms up. And shock the shoulders. And lift it down again. If this exercise causes pain or any other one, then don't do it. Again, the arms up, shoulders up, and out. Okay, the arms up, shoulders up, and down. And the last time. And now physical, arms together, a bit down and to the side, and again a bit down and to the side. And the last time. Now the sun diet. Take a soccer, t-shirt or tennis ball, whatever, with a long arm at the outside, and let it fall down. Let it catch the and on the other side. And the stretching. Take one arm, bring it in front, shoulders back and down. Pull the arm in and have flat fingers. Try to relax the arm, go it back with the shoulder, and then the palm up to the sky. And the other arm. In front, shoulder is back, down, pull the arm in, and flat fingers, try to relax the arm, go a bit back with the shoulder, and turn the palm up to the sky. And this was the short attention training. I thank you very much, and until next time.